recording. Um, what I'd like to talk about today is something that's been a very big gray area. Based on my discussions with mentoring students over recent years, and also in observing a lot of the listserv posts and even some presentations, I found there's a lot of confusion. And neurofeedback, there are a lot of gray areas because it's not really integrated to policy at this point on any national level, much less a state level. There's a lot of confusion about uh, scope of practice and who's allowed to do it and what they're allowed to do and so forth. And that's a constant problem for people entering the field. And I would like to try to shed some more light on the topic um, and talk about the obligations and responsibilities that you have as a neurofeedback provider with respect to being able to read the raw EEG, or in terms of obligations to refer EEG records or anything like that. And that's a really important thing, I think, for people to have a guideline on, so they feel confident. A lot of people are concerned and lack confidence on this topic. And there's even some fear around it. What do I need to know? What does a seizure look like, and so on and so forth. Neurofeedback has a history that's very mixed, with a lot of different currents entering it. There's been many different professions, medical and non-medical, psychological, that have contributed to the field, its growth and its identity. But a lot of the ideas have not been tested in the public domain, and particularly in the legal areas. And there are a lot of claims being made out there, and a lot of authoritative statements that are not based either in settled law or in any documented history of the field. And I think that can get to be a little dicey because it causes confusion and undue concern. So with that in mind, I'm going to share some arguments that I have based on settled law with regard to your likely responsibilities. This has not been tested because it has never gone to court, to my knowledge. But should it ever someday go to court, they will base it on settled law. That's what the judges will look at. So I'd like to review some of the settled law in a related field, which is chiropractic, which had a major collision with the AMA and the medical field for over half a century, as they tried to define themselves as a form of wellness or health practice. And we're engaged in that same process, and nursing went through the same process too. They also struggled with the AMA. These organizations have to struggle for identity, and we will too as time goes by. So the more that we know about this and the more we're informed about it, the more intelligently we can deal with these issues as they arise as practitioners moving forward into the future. So I'm going to present you a document showing some legal documentation, rather than just a colorful PowerPoint, because this is really much more technical and you need to see, I think, the actual citations and so forth. So the question is here, how good must you be at identifying abnormal EEG morphology? And what's the responsible action to take if you believe you see an abnormality? And this, again, leads to scope of practice dilemma. So let's refer to our board. For starters, the BCIA Blueprint of Knowledge outlines the general knowledge base each practitioner should acquire to be competent in neurofeedback. In Section 3, under Instrumentation Electronics, in Section C6, it requires clinicians to know the following: clinically significant raw EEG waveforms, like mu, spike, and wave, which is an epileptiform and an abnormal activity, SMR, sleep spindles. So here they're mixing normal and abnormal variants here. I'm not sure why they did that, but they define it more in another section. So this is just getting started. Most of this is about normal variants. Mu, SMR, sleep spindles, K-complex are things that you should be able to recognize for your test. They don't have that much application for most of us clinically, and I think I speak from a position of authority, dealing with hundreds of clinics over decades and mentoring a lot of people. Most of this stuff never comes up. Mu sometimes comes up, and SMR. I think it would be valuable to be able to recognize on a regular basis and relate to that. The sleep spindles and K complex, those are valuable in watching people get drowsy. That would be more valuable if you're doing a map. But there are many other things you have to look at when you're doing a map to identify drowsiness too. Okay, so this ability to identify abnormal waveforms should probably include basic abnormalities, which they started to cite there, which are spikes, sharp wave, spike, and slow wave patterns. And to acquire an extensive skill at identifying these abnormal waveforms requires actually a 12-month residency in most neurology programs. So if you haven't done that, you're not expected to have the skill level. Now, you may acquire it if you wish, but it's not required of you from a legal perspective. And you can't deploy that skill if you acquire it in your clinic because it's illegal unless you have a degree in neurology, and a degree in neurology with a specialty area, and the neurology community is very specific about this. Neither are you responsible if you fail to identify these patterns, since it's not legal for you to identify those patterns. There's a double jeopardy there. If, however, you notice them, it could be helpful to your client to forward your record to a neurologist to confirm or disconfirm the pattern, but it's unlikely that it's required based on legal precedent. Now, I don't say that in a general and unenlightened way. I'm going to actually show you precedent. So there's important considerations to make with respect to forwarding a record. I have interviewed several neurologists on this point, and they're not that interested, believe it or not, in spending time looking at all of your records from untrained neurofeedback providers, especially newbies, about abnormalities. And a large part of the reason for this is that so much of it's artifact. The mistake that most new people make in the field of neurofeedback is to mistake artifact for epileptiform activity. It's so common, and it's amazing to see highly trained professionals in other fields think they're seeing that and convince themselves that there's something important going on when it's just a saturated amplifier or electrode sway or something. So you really don't want everybody doing this unless they've had years of doing neurofeedback and looking at abnormal wave patterns. And so the other thing is that there's just not enough neurologists to go around to do this. And I've literally talked to them about it. They said, well, we can't do that. We don't have enough people to do that. We'd have to give up our practices. Now, the other thing is that the solution for neurologists is if they do recognize an abnormality, and it's unlikely you're going to capture it, because to capture these abnormalities is very tricky. It requires a lot of things like photostimulation, drugs, sleep deprivation. It's very difficult in many cases to elicit epileptiform activity. It's rare you see it, and it's rare you have the skill to identify it unless you've been through a special training program. So you start to wonder, well, why do I need to know it? Well, we'll get to that eventually. But I think it's very important to understand this. If the neurologist sees a problem, the most likely solution is going to be to recommend a drug, because that's the main tool, something like Neurontin or something along those lines. So typically individuals come to you with a diagnosis as a neurofeedback practitioner, because you're not allowed to diagnose, unless you have a health degree that gives you a specific diagnostic privilege in specific areas. And anybody who's a practicing clinician already knows that. And you have to check with your board in each state to see what your rights and responsibilities and what your scope of practice is. You're responsible for that, and you know that. So when people come to you as a practitioner, they're going to come to you with a diagnosis. Most of the people with seizure disorder come to my clinic with that diagnosis. I have never diagnosed anybody with seizure disorder, and I would never consider. I am not qualified, regardless of how good I am at reading the raw EEG. And I'm better than a lot of neurologists, but I would never, ever consider that. It's not legal. That's not appropriate. Okay, so they come to you with the diagnosis and maybe an MRI and maybe a medical EEG. And they're requesting neurofeedback from me or from you because they're not responding to medication very well, or they want to try something different. And that's where you, as a neurofeedback practitioner, can do SMR training to calm down their central nervous system, gate their thalamocortical loops, and maybe help them reduce the frequency and severity of seizure, just like you could help reduce headaches by calming down the central nervous system. It is a fact that seizure activity is most likely to occur, either early in the morning, around 5 or 6 in the morning, or when you're emotionally very overwhelmed, or you have too much sympathetic arousal, or when you're too dehydrated. I mean, these are like common reasons that people have these things, or if they get really exhausted, overtired. So, you're going to be calming down their central nervous system to give it more resilience. And there is research in our field. Barry Sturman did 30 years of research to show efficacy with control group design and published it. So, you're certainly on very strong grounds in doing neurofeedback to help people calm their central nervous system to reduce this activity. And now, there are people, like I've said, who advocate. In fact, I've heard people say should. And whenever somebody says should, you should immediately think there's something wrong here. Red flag should go up. Should is part of the Judith Beck's list of the way people think when they're moving into depression. It's shouldism. It's a semantic error that people make. There is no should, technically. It's a word that is best not used very often. But if you see authoritative statements, always doubt first, then ask for sources, and then consider the plausibility. This is whether in neurofeedback or anywhere else. So we know that it's unpractical because there's not enough neurologists to meet demand. On the other hand, if you are a neuropsychologist, and you have specialty in that area, and you work with neurologists, there's a case where knowing your waveforms could be very valuable, as it allows you to dialogue with the neurologist and work with the neurologist if they're interested. So that's a case where, yeah, this is especially valuable. And if that's who you are, then I recommend you go through a neurological residency program to gain skill levels so you don't waste the neurologist's time. So to every neurofeedback practitioner in the field to submit professionals would make our field subservient to the medical field and confuse neurofeedback with medical procedure. And that's a really important point. This is the same battle that nursing and chiropractic went through with the AMA. I personally am not interested in seeing neurofeedback become subservient to the medical field. We're not medical practitioners. We don't engage in medicine. We engage in operant conditioning, and we use psychophysiology. And that's why the AAPB is called the Applied Psychophysiology. EEG neurofeedback is biofeedback. By definition, it's learning. It's not an intrusive medical intervention. And that's been written up in all of the biofeedback literature and published for decades. So our primary mode of analysis in this kind of standalone venture that we're developing out there is quantitative. Even when you're not doing a QEEG, you're doing quantitative EEG. You're looking at bands of EEG and looking at amplitude, dominant frequency. You're looking at symmetry. These are quantitative measures. They are not morphological like mu, spike and wave, or anything like that. And that's what you're doing. And that's where your expertise is. That's where we claim it is in our field. So this is a consequence of our paradigm and how we assess and remediate symptoms and conditions through operant conditioning. We train the central nervous system rather than drug it or cut it. This is a fact that distinguishes us from the activities of medical intervention involving diagnosis and curing. We do not diagnose, we do not cure. If you put that on your website, the FDA will come after you. I've seen them do it regularly with people. So we share the technology of EEG with the medical field, but that does not make us medical specialists. And a lot of people get confused on this point, that because we share a class 2 medical device with the medical field, people are confused. Are we doing medicine or not? No, we are not. And there's precedent for that. And the precedent is X-ray. So we'll use that as an analogy. Chiropractors share X-ray with orthopedists and other medical specialists, but they are not medical doctors. They, like neurofeedback practitioners, they have their own paradigm. They use X-rays to identify subluxations, and medical doctors do not. They don't believe in it. They've called it quackery, in fact. And they tried to squash chiropractic, and they went after them in the 60s and 70s with a vengeance. And the AMA was stopped, and they were stopped on the basis of restraint of trade. And that's the same reason they'll get stopped if they ever go after us. Their intervention is unique, and so is ours. We're doing operant conditioning with EEG. Medical doctors don't do that, most of them, and if they do, they learned it from us. So they're not responsible for identifying medical problems, and they're not trained to do so. Chiropractors sound like a bold statement? It's not. It's settled. It is settled law going back decades. Okay? And one of the key cases was Kirkman versus Hintz in the Wisconsin Supreme Court. And so let's look at that case going back to November 1987. According to Whaley, and this is another case, a chiropractor does not treat or diagnose disease. Instead, the chiropractic practice is limited to the analysis and correction of subluxation. The chiropractor's function is to locate the subluxation. If it exists, adjust it back to the correct position, and then allow the body to restore itself to normalcy. Does that not sound familiar? Allow the body, after moving it back to a normative pattern, allow the body to restore itself to normality. A medical doctor's practice, on the other hand, is completely opposite. The medical doctor is concerned with the diagnosis and treatment of diseased area through the use of drugs and surgery or other techniques. This is from court records, just to make this clear. So I'm saying, like chiropractors, we don't diagnose or treat disease. Our function is to locate quantitative EEG abnormal patterns, and if they exist, adjust them back to the correct pattern, push them back towards a normative range using operant conditioning, not drugs or surgery, so the CNS can restore itself to normalcy. It's a very strong parallel there. The court records say, although chiropractors are permitted to use some medical tools when analyzing and treating a patient, this overlap does not transform the practice of chiropractic into the practice of medicine. Note that. That is one of the most important statements on the record in this case. Because they use medical tools when analyzing and treating a patient, that does not automatically mean they're in the practice of medicine. And people get very confused about this point, but it's been settled. So be clear on that. You're using a class 2 device, but you're not doing medicine. Although neurofeedback practitioners are permitted to use a medical tool like EEG amplifiers, when analyzing and treating a client, this overlap does not transform us into a practice of medicine. In the court record, it says, our conclusion that chiropractors should not be held to a medical standard is supported by an examination of the limited legislative authorization of chiropractors to diagnose and or analyze and treat by chiropractic means. So they have a limited scope of practice, and so do we. Neurofeedback practitioners should not be held to a medical standard for the same reason. If you hear people making that argument anywhere on these listservs or the internet, they're arguing against settled law, and they have to prove that they have evidence to the contrary and document it. Ask them for it. Okay, because neurofeedback practitioners are prohibited from using their knowledge of EEG morphology and do not obtain a degree in clinical neurology, participate in a neurology residence program in which they are trained in electroencephalography and EEG interpretations, they cannot analyze the morphology of an EEG for diagnostic purposes. That would be illegal. And here's from the records. As previously noted, a chiropractor is limited to his or her license to practice within the scope of chiropractic knowledge and training. Consistent with this limitation, we hold that a chiropractor is required to determine whether the patient presents a problem which is treatable through chiropractic means. When a client comes to you, are they treatable by reducing central nervous system activity through operant conditioning? That's the question you're asking yourself as a neurofeedback provider. If the patient has a problem which is treatable through chiropractic means, the chiropractor may provide treatment to the patient. However, the chiropractic must refrain from further chiropractic treatment when a reasonable chiropractor should be aware that the patient's condition will not be responsive to further treatment. So it's based upon what's called common chiropractic knowledge of practice. All right? That's a legal concept. In your scope of practice as a neurofeedback practitioner, if you are aware that what you do is not likely to help the client, it is your legal duty to inform them of that. Now, if they still want to continue with treatment, that's their legal right, as long as you tell them the risks and benefits. And the FDA is importantly noted for looking for, on your documentation in your clinic, whether you list risks and benefits. If the client or patient knows the risks and benefits, then you are covered. That's important to know. And I presented that in other presentations we went over on the FDA and class 2 devices. If the patient presents a problem which is outside the scope of chiropractic treatment, then the chiropractor must inform the patient the problem is not within their license to treat. So that's one of the areas you could get into trouble if you aren't clear on that. Neurofeedback practitioners should determine if the presenting problem, is something they can do about. We just said that. Having explained to the patient that the problem is not within the chiropractor's license to treat, the chiropractor does not have a duty to refer the patient to a medical doctor. Now, a lot of you think you do, and I've mentioned that. You don't legally have an obligation to refer your patients. Don't. And the settled law would probably carry over. Now, ethically, you may feel you do, and that's fine if you do it from an ethical perspective, but you're not legally required. The neurofeedback, okay, so now there was a later case drawing on this precedent that I just went over, which further clarifies the issues and explain why you do not need to identify abnormal variants in the EEG and refer to a neurologist. Oop, better correct that. Of course, somebody's going to have a fit, right? Because there's a typo. That's a common feature of anxiety and control issues. A chiropractor, Dr. Murray, did in fact use X-ray technology, like we might use imaging technology like QEEG. And he did it to review a client's status from a chiropractic paradigm to see if there were subluxations, like we might look for abnormalities in quantitative EEG, and failed to detect a cancerous tumor and was sued for his failure. Now, why this is so nice is because I heard a QEEG specialist years ago saying, well, you need to know what all this stuff looks like because he had discovered a tumor in the right frontal area of somebody's brain that hadn't been discovered. He was a psychologist. What he did there was technically illegal, but he was working closely with a neurologist and had been in constant communication with specialists and submitted it to them. And because of his high level of expertise and specialization as a neuropsychologist, it all was fine and everybody was happy. But had he not detected it, he would not have been responsible legally at all. So the Wisconsin Supreme Court in in the case we just read, implicitly determined that chiropractors do not have a duty to recognize medical problems because to do so would require chiropractors to make medical determinations, which under Wisconsin law they're not licensed to make. Second, as a matter of law, recognition of an abnormal mass in a lung area, which is revealed by an X-ray, is not within the practice of chiropractic because it concerns a body organ which is not part of the spinal column, skeletal articulation, or adjacent tissue. Thus, detection or recognition of a mass as an abnormality would have amounted to a recognition of a medical problem. That's not recognition of a medical problem. If you don't capture a tumor in your QEEG, you're not capturing a medical problem. That is not within your scope of practice, and you are not legally liable for that. Finally, we conclude that this case was capable of resolution without the assistance of expert witnesses. Accordingly, we hold that Dr. Murray had no duty to recognize or inform Mr. Pillock that the mass of tissue revealed by his X-ray was an abnormality, and consequently, trial court correctly granted summary judgment to the respondent. So there's a clear precedent here to support the policy that as practitioners, we are not responsible for detecting medical abnormalities, EEG, or tumors, just as chiropractors are not when they're using X-rays. Like chiropractic, psychologists have a unique professional paradigm that identifies CNS arousal dysregulations. Psychophysiologists, I meant to say, and they're not qualified to diagnose or treat mental conditions. On the other hand, if a clinician is a medical doctor, an MD or physician, and he or she has the option of making a diagnosis using QEEG in conjunction with medical testing, and then implementing neurofeedback in conjunction with other medical interventions in an effort to manage or cure illness, that would be fine. I know many doctors who I've trained who do that. And they had to go through a lot of work to understand morphology. And they still know their limitations, and they know they're not neurologists, and they know the limits of what they can do. So they would be obligated to identify any illness utilizing medical testing liable for their failure. Okay, so that's the first half of what I wanted to talk about. That's the law, settled law. And I think it sheds a lot of light on what we're doing. Now, why are we learning morphology, and how much do we have to know it? There's not a lot of clarity. There's not been a lot written on that in the field of neurofeedback. And there's a lot of unenlightened arguments and discussions and claims. So what I'm going to do is just start to go over a little bit of that. I'm not going to go over all of artifact because most of you should have learned that or should be learning that. And if not, you'll be able to read this article because I will post it eventually. So what I'd like to talk about is just the significance of knowing your artifact. It's important to be able to identify artifacts, and it's in your scope of practice because without knowing that, it impacts our practice and the effectiveness of our practice and the exercise of our skill sets. All right, the quality of your EEG record is critical with reference to the accuracy of assessment and quality of training. If you're getting too much artifact in your QEEG or in your trend lines and you don't know it, you're not going to be accurately reading what's going on. Your assessments and of status and progress are going to be biased in a direction which is going to undermine the efficiency of what you're doing. So this consideration leads us to the secondary question of what skill level practitioners should have regarding reading morphology. A basic skill is useful, and this is what the BCIA has posted in Blueprint of Knowledge. Now, of course, again, it's a little confusing the way that they put this all together, so I wouldn't be surprised if people were confused by it, because up here, the first area is looking at artifact, electromyographic and electroocular, muscle tension, eye movement, cardiac, sweat, cable sway, 60 hertz noise, especially coming from your wall socket, your line noise we call it, and dirty electricity, and electrode pop. These are things you need to know to get your BCIA certification. You should know what those look like, because otherwise you'll not be eliminating artifact or understanding what artifact is causing problems. And I see this a lot with everybody when I start them out with neurofeedback. The biggest mistake people make is they mistake electrode sway and amplifier saturation for something really big and bad going on in the EEG, and it's just an artifact. They get over that pretty quick, but the thing that often they stumble over is EMG, electromyographic signals, entering the EEG leads, muscle tension, getting into the EEG and inflating high beta and consequently beta, and it's getting up around 8 or 10 microvolts, and they're thinking it's real, and it usually never is. It's usually always muscle tension. So that can lead to confusion and misunderstandings, and so that's a really important thing to know. So there's an example of why knowing morphology is very valuable. To know what muscle tension looks like in the raw trace, whether you're doing a map or whether you're doing a training, is important. So that speaks to the fact that these concerns and skills are well-founded, and you should be competent in the areas. The second category relates to developable norms and recognizing differences in eyes closed and eyes open EEG. And that's important to be able to distinguish that from artifact. And the third is related to arousal. And of course, we talk about arousal all the time and how it relates to trend screen symmetry and how it relates to activation. I mean, that's a common topic on the New Mind listserv, and especially on the Lunch and Learns. Everything's built around those topics. So, obviously we want you to know that, and that makes you an efficient practitioner. What can be even more problematic is that if you choose to work with S-Loretta and do S-Loretta mapping and S-Loretta training, and a small percentage of the neurofeedback field does do that. A lot of them are neuropsychologists, research psychologists, things like that. If you don't have 100% artifact-free data, your S-Loretta will not be 100% accurate. I mean, from a mathematical perspective, S-Loretta will be inaccurate from an anatomical perspective quite frequently, and that's impossible to avoid. It's just a fact of biology. But from just a mathematical perspective, you have to have it artifact-free. And as you know, that's very hard to achieve with the QEEG, and even harder to achieve with somebody who's training. There's quite a bit of artifact while you're training, and in those periods, that can really throw off your Z-score training unless you have some kind of auto-artifacting, or you're paying very close attention to what's going on and managing it very closely. That takes a very high skill level. And a lot of practitioners aren't interested in going and mastering those higher skill levels. A lot of them say, I'm not interested in a second degree in medicine and neurology. I just want to do basic neurofeedback and help people. And that's fine, and there's nothing wrong with it. And the majority of the people out there are doing it. But of course, you'll hear people who authoritatively say, you should do it my way, or you're not ethical if you don't do it my way. And that's really what we like to call vendor shite. It's more vendor stuff than it is actual fact. But the arguments pro and con will go on in a lively fashion, probably for decades to come. So, managing artifact poorly can lead to lousy brain maps and poor training sessions. And not many of the software packages out there are doing live artifacting while you're mapping or training. Our software is one of the few that does. And some of the ones that do out there do through a method called ICA, Independent Components Analysis, which Thatcher argues alters the coherence and phase of your map in a way that's not valid. We'll let Bob argue that with Jay and others, Jay Gunkelman and others who propose that it doesn't, and we'll just have to watch from the sidelines. It's a highly technical argument, and they'll have to resolve that one. But we don't use that type of artifact rejection in our system. We do not use ICA, and so ours is not altered in that way. So you don't have to worry about that. Well, from this point on, my article goes through just the basic types of artifact, and I don't want to spend time here right now doing that. You can read it. It's all stuff you should know, but covers it again in detail just to make sure everybody's up to speed on what they're supposed to know about. So you know, I don't want to go beyond that in the discussion, but I do want to talk about this final aspect of the article. And I'm just trying to get my screen out of the way so I can get to that. Okay. The artifact types, electromyographic, electroocular. And that's one more people should know about. Okay, so that brings us to the question, are spikes and sharp waves always significant, and what can you do about them? Okay. None of the artifact recognition requires a high skill level of interpreting and reading an EEG trace. Artifact is pretty basic. You should all know how to do it. Corey Hammond's done a great book with Jay Gunkelman on this topic, and you can probably learn quite a bit from that, as much as you need for neurofeedback. There are those who promote those higher skill levels, but the responsibilities and pitfalls of that promotion of higher level I think have been addressed above in the legal arguments. You may be able to recognize abnormal activity, but you're not allowed to comment it or diagnose based on it if you do not have the appropriate medical license and board certification. And to do so violates the law. So what can you do about them if you see them? Well, a brief review of the neurology literature cautions even neurologists as far back as 1968 about the problem of overinterpretation. It's very easy even for trained neurologists to overinterpret raw EEG. They argue that positive spikes, spike wave phantoms, and psychomotor variants are recognized in the literature, but it's unclear they have any clinical significance. So those are things that require quite a skill level. You may say, oh, there's a spike or there's a sharp wave, but you may not know these more subtle categories and what they mean, and that they may not have any clinical significance. One author noted that benign epileptic variants such as benign sporadic sleep spikes, wicket waves, 14 and 6 hertz positive spikes, right? 6 hertz spike waves, rhythmic temporal theta bursts of drowsiness were common in up to 18% of the population, depending on the country, and they do not result in problems. So there's a fair amount of benign spike wave activity that has little or no relevance to client status. So if you're not interpreting it right and you're not an expert, you're wasting people's time and money and maybe unnecessarily concerning them and yourself. And so you should get a sense here that the skill level's pretty high. Furthermore, Smith argues that interictal epileptiform discharge does not in itself indicate that an individual has a seizure disorder. So spiky or rhythmic phenomena such as 14 and 6 hertz spike, etc., same thing we just discussed, and subclinical epileptiform discharge in adults have lower zero predictive value for epilepsy. So even though those things are present, there may be no epileptiform consequences. So Boutros in more recent times argues that a medical EEG can have a limited but definitive role in managing some psychiatric conditions, and that isolated epileptic discharges can be associated with panic attacks, dissociative symptoms, repetitive aggressive episodes, rage attacks, antisocial behavior, and attentional issues non-responsive to medication. And much of this shows up in the form of spikes. Now, this is what, we had a recent speaker talking about. Jay Gunkelman talks about this. Some other people who have more expertise in these areas like us to know that some of the psychological behaviors we're seeing may be related to this. My advice would be, I think, a good idea here is if the person hasn't been diagnosed with this and you're training them for these things, and a large percentage, most people with these problems, they're just purely psychological, and they're not responding to your neurofeedback. Well, first of all, your neurofeedback is doing SMR, so it might reduce some of these behavior because it's diminishing this abnormal activity, which Barry has shown is possible. But if they still don't respond, then you might want to send them to a neurologist and let them decide, if there's something more they can do. That's an area where you would have a right to say, okay, I've done my due diligence, my neurofeedback. This person still has issues. I know as a trained clinician that those issues can sometimes be due to, abnormal variants. And, I'm just going to ask them to go to a neurologist, see if he can discover or help anything. That's about all you can do. And that's a very reasonable thing to do. And if the neurologist wants to come back to you and talk to you and talks about spikes and sharp waves, now that's where your knowledge of them can be valuable, because now you can have an intelligent conversation. The authors of these kinds of papers note that standard EEG tests should be ordered by a physician who recognizes these symptoms, your neurologist. They further note that QEEG has no certain clinical usefulness with regard to these conditions and is not a substitute for a standard EEG test. Okay, so think about that. Your QEEG has no clinical value except within your field of neurofeedback. Given the fact that a medical EEG is very different from a QEEG, it should never be the basis for a medical diagnosis, and those performing QEEG without a medical license should not assume medical responsibilities. It's not my opinion. That's the opinion of the neurology community. The presenting symptoms as observed by a physician, according to all the authors, should be the basis for a medical EEG. Sermon demonstrated that abnormal activity is responsive to neurofeedback, and consequently, those doing neurofeedback will likely reduce this activity whether they know it is present or not. While Boutrous notes that the effectiveness of treatments usually utilizing medications to eliminate spikes in autism and similar developmental disorders remains an open question. They don't even know if it helps. Hence, the people showing up at our door for autism. So, what's your skill level? Much of the literature here we can see shows that whole categories of spike and sharp wave morphologies do not result in symptoms, and other categories do, and making distinctions are difficult. One author notes that differentiating normal variants from meaningful spikes is so difficult that only EEG epilepsy specialists should be doing it. EEG should not even be read by general neurologists, and they do it. So where do we get off? How do we do that? We don't. Why does BCIA require practitioners to know about these things? It would appear upon consideration of what we've seen that this ability would be of most value when talking about cases where psychiatrists and neurologists who are qualified are discussing these things with us, like I said. Moving forward, we want to be able to talk to this community and refer to them from our knowledge base. Oh, this is, neurofeedback's not doing anything. Sometimes these behaviors are related to abnormal neurological conditions. I'm going to ask you to go to a neurologist, if you're interested, and check it out. And if he finds something, he can talk back to me, and I'll understand what he's saying because I've studied these to some degree. So in closing, I'd like to say that our job's not to correct abnormal EEG morphology through drugs and surgery, but to correct abnormal quantitative patterns through operant conditioning. There's a difference between a medical approach and a psychophysiological approach. One of the important differences between us and chiropractic is that we've not been around as long establishing ourselves as psychophysiologists. And the rigor that we used to neurofeedback, I think, is pretty unmatched in most areas, and medicine too. There was a gentleman, a medical doctor named Don Rettelmeyer, who did a lot of work on statistical analysis. He worked with Danny Kahneman, who's a very famous mathematical psychologist, and they worked together on decision-making theory, and they've implemented that into the medical establishment. They try to, particularly up in Canada. And statistical thinking requires a special kind of training and thinking that medical doctors and lawyers don't learn that well, and they're generally not that good at it. That's not my personal statement. That is published research. I read articles on it in graduate school. We had to learn that kind of thing. So it's becoming a preferred methodology to do statistical analysis in medicine, but it's also becoming a preferred methodology to do statistical analysis in EEG biofeedback. It's a sign of our times. The ability to access computers and manage large amounts of information. So our perspective and method is non-medical, and it's statistical, and it requires different training and a different kind of thinking, and should not be confused with medical EEG practices. Neither should our responsibilities, skills, or legal obligations or our practice be confused with medical EEG practice. Okay, so that's what I have argued, and so I'm going to unmute all of you, and we've got about 10 minutes or so to discuss this or start bringing it up, and we can talk about it more moving forward in other luncheon rooms, but I think this is a really important topic for you to know about, to think about, and to consider the arguments.
It is. Are you still unmuting, folks?
Yep, I am.
Richard? Mm-hmm. Does anybody have any questions?
Any comments? And we're open to confer.
Yeah. Richard, thank you very much for doing this. You dug into the legal literature, which most of us wouldn't know even, how to approach, and I'll sleep better tonight.
Good. That was the primary idea, Michael. That was my primary objective here. We had some alarmist posts and statements that I thought were a little unresponsible and not well documented. So I felt it was really important. Okay, this is an issue. Rather than have a dirty fight on the listserv and sink down to the level of some of the other listservs, let's just do point and counterpoint. So we're published both of these points of view on the New Mind YouTube site. So you can listen to both sides and consider for yourself the soundness of the arguments and make a decision, but also help you decide when ISNR wants to ask the membership, what do you think? Or BCIA makes statements, you have a basis for making a decision. And I just think that a lot of people have been too uncomfortable not knowing this more clearly.
Well, we get into trouble, I think sometimes when you go to a conference or you're looking at things on a listserv and somebody comes across with so much authority, we make the assumption they must know what they're talking about.
Yeah.
Versus thinking that, this might be an opinion. So now you've got a little more, backup here with the work that Richard did in citing some articles and giving examples and all that to give yourself a little bit more confidence about not feeling scared, if you see something. And we're here, we do these webinars 3 times a week. So if you have an unusual pattern, take a screenshot.
Do you know that?
I did that. I met my wife last week, and I sent it off to Richard because I think she was actually having a panic attack during the eyes open portion of doing a brain map on her. And so he's going to take a peek at it. If it is, we'll give you an example of what a panic attack may look like during, on a map. So, always feel free to pose questions. And we always say here, there's no such thing as a stupid question. Go ahead. Somebody had a comment.
Okay, good. All right. I spent years and years sending what I thought may have been something significant to Marvin Sams, and I never got back one. he said was not artifact. He said, nah, it's artifact. I mean, he got tired of them after a while. But I really had a good opportunity to see how hard it is to capture something significant in the EEG and how much training it takes. I mean, spikes are easy to capture, and so are sharp waves, and you can fairly commonly see those. But a lot of them don't have significance at all. And you're not allowed to comment on them, really. You can refer somebody to a neurologist, but you're not required by law. But I think ethically, I would consider doing it. But you have to do it in a way that doesn't upset your clients, because the odds are that you're seeing something benign, or or it's artifact. Because if it was something more serious, typically, it has to be discovered by a medical specialist, and even if you send him to a neurologist, unless he's has a specialty in EEG, he's not going to be able to really tell it, and might act as if he has that ability. And that's what the neurology community is concerned about, and says, just because you're a neurologist doesn't mean you should be reading this stuff. And they say, and apparently a lot of you are, so please stop. So that's another, you have to refer to the right kind of neurologist. And there are people out there. Jacob is in contact with them, and I think other people are. Dick Gennardi is in contact with neurologists. Rusty Turner comes on here periodically and does presentation. He's a neurologist, does neurofeedback. All these people have specialties in that area, and so if you're concerned, you can send something to them, and they'll let you know.
Well, all righty.
Okay. Thank you for your patience and your